Now let's proceed to Group 4 ABO Discrepancies. So these are categorized as miscellaneous problems where the results of the forward grouping or the testing the red cells do not match the expected results of the reverse grouping or testing the serum or plasma. Unlike other groups that focus on specific missing or extra antigens or antibodies, Group 4 is a catch-all for unique biological interferences. Common causes of group 4 discrepancies have cold reactive autoantibodies, unexpected ABO isoagglutinins, cold reacting non-ABO autoantibodies, and multiple cell populations. We also have cis-AB phenotype and as well as the reagent dye sensitivity. Let's talk about the cold reactive autoantibodies. This is a common cause where a potent autoantibody like your anti-big eye coats the patient's red cells so heavily that they clump spontaneously in the presence of any reagent, or it can cause a false positive reaction in the forward typing. Because the antibody is in the serum, it also clumps the reagent A1 and B cells used in the back typing. Next, we have unexpected ABO isoagglutinins. So this occurs when a patient has a subgroup that produces an antibody against the main group. For example, an A2 individual may produce anti-A1, so which will cause their serum to react with reagent A1 cells in the reverse typing. For cold reacting non-ABO alloantibodies, if a patient has an antibody like anti-Big M or anti-P1 or anti-LE or anti-Lewis in their serum, it may react with the corresponding antigens that happen to be present on the reagent A1 or B cells. For multiple cell populations, this happens if a patient was recently transfused with a different but compatible blood type. So we have group O cells given to a group A patient or has undergone a bone marrow or a stem cell transplant, resulting in a mixed field reaction. We also have the cis-AB phenotype. So it's a rare genetic condition where both A and B genes are inherited on a single chromosome. So this can lead to a very weak B antigen and sometimes an unexpected weak anti-B in the serum. Next, we also have the reagent dye sensitivity. So some individuals have an antibody against acreflavin, which is the yellow dye used in anti-B reagents. So this causes the patient cells to clump when the reagent is added, even if they aren't group B. So how are we going to resolve group 4 problems? So we can incubate and wash the red cells at 37 degrees Celsius so that it can disperse cold autoantibodies. We can use pre-warming technique in warming the serum and reagent cells to 37 degrees Celsius before mixing them. Prevents cold reacting antibodies from interfering. We also have antibody identification. So if a non-ABO antibody is suspected, a full antibody panel is performed to identify it. The reverse typing is then repeated using reagent cells that lack that specific antigen. So you can also have chemical treatment. So reagents like your DTT can be used to break down certain antibody structures to stop them from causing spontaneous clumping. So here is the summary of your ABO discrepancies. So while many discrepancies are caused by technical mistakes, so sample-related problems arise from specific biological properties of a patient's or donor's blood. So again, for group 1, we have weak or missing antibodies. So these discrepancies are found in the reverse typing and are the most common type encountered in the laboratory. So they occur in a patient does not produce the expected ABO antibodies based on the Landsteiner's rule. Common causes, you have newborns who have not yet started producing their own antibodies or usually detectable at 3 to 6 months. We also have elderly patients whose antibody levels have naturally declined. We also have patients with hypogammaglobulinemia due to diseases like leukemia or lymphoma, or those on immunosuppressive drugs. So in order to resolve your group 1 discrepancy, we often incubate the serum and reagent red cells at room temperature for 15 to 30 minutes or at 4 degrees Celsius to enhance the weak antibody reaction. For group 2, the problem here is the missing or the weak antigen. So these discrepancies occur in the forward grouping and are the least frequent type. So they happen when the expected A or B antigens on the red cells are either absent or so sparse they cannot be detected. So common causes of group 2, you have rare ABO subgroups like A3 or AX that have very few antigen sites. Disease states like leukemia or Hodgkin's disease which can temporarily depress the expression of antigens. We also have the acquired B antigen or the acquired B phenomenon, which is found in group A individuals with lower gastrointestinal diseases. The bacterial enzymes will modify the A sugar so it mimics the B sugar, causing a false reaction with your anti-B reagents. So in order to resolve group 2, we can incubate the red cell reagent mixture at lower temperatures, or treating the cells with enzymes can often reveal these hidden antigens. For group 3, it's related to protein abnormalities. So these discrepancies are caused by high levels of protein in the patient's plasma, which causes the red cells to stick together physically, mimicking a real antibody reaction. So common causes, you have rouleau formation. So red cells stack like coins under the microscope. This is seen in patients with multiple myeloma or Waldenstrom's macroglobulinemia. We also have Wharton's jelly. It's a gelatinous substance in cord blood samples that can cause non-specific clumping. So in order to resolve group 3 discrepancies, we can resolve it by washing the cells thoroughly with saline or using the saline replacement technique in order to distinguish true clumping from rouleau formation. Next, we have the group 4. Group 4 is related to miscellaneous problems. So this group contains various unique biological issues that do not fit into the other categories. So common causes, we have cold autoantibodies, like your anti-big eye, which can coat the patient's cells and cause them to clump spontaneously, regardless of the blood type. We also have multiple cell populations. This happen if a patient was recently transfused with a different blood type, such as in group O cells given to a group A recipient, or has undergone a stem cell transplant. For unexpected ABO antibodies, for instance, an A2 individual may produce a naturally occurring anti-A1 antibody that reacts with the reagent A1 cells in the reverse type. So in order to resolve group 4 discrepancies, we often require it warming the blood to 37 degrees Celsius to dissipate cold antibodies, or performing specialized adsorption techniques to remove the interfering auto-antibodies. So technical errors are the most frequent cause of ABO discrepancies, which occur when the results of the forward grouping or the antigen testing do not agree with the reverse grouping or antibody testing. So these errors are generally preventable by following standard operating procedures and the manufacturer's instructions. So for specimen mix-up, this occurs when a blood sample is collected from the wrong patient or labeled with the incorrect identification, or when tubes are transposed during testing. So a mix-up can lead to a discrepancy if the forward and reverse results obtained from the sample do not match the historical blood type on file for that patient. It is a leading cause of fatal acute hemolytic transfusion reactions. For too heavy or too light red cell suspension, for too heavy red cell suspension greater than 5%, this creates a state of antigen excess or a post zone. There are too many antigens relative to the number of antibodies, so which prevents the formation of a visible lattice network, resulting in a false negative or missing reaction. If too light, less than 2%, a suspension that is too thin can lead to prozone effect or antibody excess, or fall outside the zone of equivalence, making reactions appear weaker than expected or entirely negative. Failure to add reagents. So if we fail to add a reagent such as anti-A, anti-B, or reagent cells such as the known A1 or the known B cells, there will be no reaction even if the corresponding antigen or antibody is present. So this results in a false negative result. In order to prevent this, it is a standard rule to always add the clear solutions or the reagents first and red cells second to visually confirm that both components are in the tube before mixing. Next, we have the missed observation of hemolysis. Hemolysis is indicated by a pink to red supernatant after centrifugation. It is a positive indicator of an antigen-antibody reaction in which the complement has been activated. So if we only look for clumping or agglutination and misses the fact that the red cells have been lysed, it will incorrectly we will incorrectly record a false negative result. So this is particularly dangerous as it represents a very strong reaction. Next, we have failure to follow manufacturer's instructions. So reagents are licensed by the FDA based on specific procedures, such as your specific drop counts, incubation times, and temperatures. So deviating from these instructions, such as using the wrong temperature or omitting a required incubation, can lead to weak or missing reactions. For example, some monoclonal reagents require specific pH levels to avoid false positive reactions, like those seen in the acquired B phenomenon. So under or over centrifugation of tubes, so centrifuges must be calibrated to define the optimal speed or the revolutions per minute and the time to force your cells together to form for a lattice formation. So over centrifugation, this packs the red cell button so tightly that it cannot be easily dispersed. This may lead to an interpretation of a false positive agglutination. While under centrifugation, on the other hand, this fails to bring the sensitized red cells close enough to develop cross-linkages, potentially resulting in a false negative or a very weak reaction. For incorrect interpretation of or recording of test results, so this includes transcription errors, so recording a correct result on the wrong patient's record, or subjective errors in the grading of the strength of a reaction. So because grading is qualitative, misinterpreting a weak or a 1 plus reaction as negative or failing to notice a mixed field pattern can result in an ABO mismatch. So clerical errors remain a leading cause of erroneous interpretations.